Start. We're live whenever you're ready.
Hi there. That screwed up.
Let's get the first hi there done.
Hello, my name's Dave Ellis. I'm the director for the telehealth division at UBMD Emergency Medicine here in Buffalo, New York. And we're going to talk today about the assessment and management of mild traumatic brain injury in an emergency telehealth setting. And this is an extremely common problem, as many of you know, that have managed patients in this setting, particularly in the correctional facilities. The studies show that the rate of head injury in correctional patients may be 7 times that of the regular population. So these patients have had head injuries before they've come to the correctional facilities, and they have head injuries while they're in the correctional facilities. So it's an important problem to be able to manage and to think critically about what are we doing with these patients and how are we managing it. The first thing that I always recommend when we're talking about the management of the head injuries is first ABC. Airway with C-spine control is the first. Make sure as far as how the patient's breathing, and take a pulse, check on the circulation. And this can be immediately life-saving and can take a situation where you've got a patient who's in extremis to one that is breathing spontaneously. And the most common thing that you want to be able to do is open the airway. And that's the jaw thrust maneuver is the most effective way to open the airway and allow the patient to breathe if they can breathe spontaneously. Patients who have altered mental status or decreased responsiveness will have problems with their airways in 3 ways. First of all, they won't protect their airways, so they're at risk of aspiration from vomiting or other types of material in the mouth. The second thing that they do is they don't breathe, and so they may have decreased respirations or limited respirations, sometimes with overdose in combination with head injury or other type of problem. And then the final thing that they do is that their airway can become obstructed, and you can get upper airway obstruction. And the most common reason for a patient with decreased level of consciousness to have upper airway obstruction is by the tongue falling back into the airway. If the patient's laying on their back, if the tongue falls into the mouth, so when the patient tries to take a breath in, the airway is blocked, and the patient will appear not to be breathing, or the patient may have difficulty breathing or gasping inspiration or gasping respirations. And so the easiest thing to do in that is the jaw thrust maneuver, where you place your hands behind the patient's head and lift up on the angles of his jaw to bring the jaw forward and remove the tongue off of the airway and open the airway. When I worked in a rural emergency department in single coverage as an emergency physician just out of residency, when a trauma came in, the best place that I could be was at the head of the bed, behind the patient's head, doing a triple airway maneuver and lifting the jaw forward to ensure that that patient's airway was open. And then, if they're breathing, be able to proceed with all of the activities that occur during a resuscitation. So in the same way, when you approach a patient with decreased level of consciousness, the first thing to do is to do a jaw thrust maneuver while keeping the C-spine stable. When you're stabilizing a C-spine, it's important to make sure that you can use your forearms as a bridge to hold the patient's head in place while you're going through the process of managing that patient's head injury. The second thing with breathing is, again, opening the airway may help with the breathing, but check on the depth of respirations, the respiratory rate. Are they decreased? Does the patient need a trial of Narcan to reverse an overdose which may be occurring in addition to the head injury. What other things can we do in terms of making sure that the respirations are moving easily? Does the patient need a bag valve mask or assisted ventilations in that setting to help them breathe during the initial evaluation? But most importantly, the real key is opening the airway and stabilizing the patient's neck. And finally, checking a pulse and seeing and going through your process of assessing whether this patient is a candidate for an AED. Should the patient be evaluated with an automated external defibrillator to see if the reason that they had the head injury was because they had a cardiac event, and what is their rhythm at this point, and do they need to be evaluated and possibly shocked with an AED. So again, A, B, C, check the airway with C-spine control, check for the patient's breathing, check a pulse, and if no pulse, proceed with your AED. So when you're assessing the patient's level of consciousness and how do you assess for an unresponsive patient, the key is that you provide a stimulus and you get a response from the patient. Just looking at a patient, you really can't tell if they're unresponsive or not. You have to apply some form of a stimulus. And the first level of a stimulus is to just call the patient by name, or to see if the patient responds to voice in assessing them. The second level of assessment is to provide a painful stimulus, or provide something as simple as maybe touching the patient on the shoulder, applying some pressure on the sternum, pinching on a finger, things that won't cause significant damage but will allow you to assess whether the patient is responsive to pain. So the key is in assessing for a responsive patient is you have to apply a stimulus. And so oftentimes you may say, well, the patient was unresponsive. Well, did they try to assess the patient, or did we do a stimulus response process? So the patients that are going to be unresponsive despite stimulus, who are going to have evidence of a severe head injury, those patients we're going to manage with 911 and rapid response. The ones that we're interested in today are the patients with a mild traumatic brain injury, or mild TBI. And it's defined as patients that have suffered either direct or indirect blunt trauma to the head, and they're patients that have an initial Glasgow Coma Scale of 13 to 15. And so the next question is, well, what's a Glasgow Coma Scale? In medicine, and using the Glasgow Coma Scale, it's determined on three factors: the patient's best eye opening, the patient's best verbal response, and the patient's best motor response. And so in your process of stimulating the patient, you have to see how they respond to what you're asking them to do. For example, and the point system that is on a system of 4 points for best eye opening, 5 points for best verbal response, and 6 points for best motor response. And we'll talk about it more later, but the actual full scale is not as important in this setting where you're evaluating somebody in a remote facility or in a correctional facility or a group home or wherever you're evaluating them. That in that setting, the real question is, does this patient require further evaluation? Does this patient require a CT of the head? And so in that process of determining if the patient has a mild traumatic brain injury, what you're most interested in are the initial responses. So for the best eye opening, when you speak to the patient or provide a verbal response? Are the patient's eyes open when you just see them, or do you have to provide a verbal or painful stimuli? From a verbal standpoint, is the patient oriented? Can they talk to you? Do they know where they're at? Do they know what month it is, what year it is? Or are they confused as you talk to them? Those are going to be the patients that we're going to be more concerned about. And finally, on best motor response, the patient who gets a score of 6 is a patient who obeys commands and follows your directions as you're managing them. Another 5-point patient under best motor response will localize pain, meaning that if you touch them in a certain place, they'll grab that hand or they'll try to push that hand away, but they'll localize the pain. And those really are the main ones that we're interested in terms of assessing a patient. Are the ones that can get a patient 1 or 2 points off, which may put them and keep them in the range of a mild traumatic brain injury, versus the more seriously injured patient or altered mental status patient who's going to be farther down in the scoring system and more likely to have to be immediately transported from the facility. The other criteria for a mild traumatic brain injury is that they have some somatic, cognitive, or affective symptoms. They have some feeling of pain. They have some dysfunction in terms of their process of thinking, where they may have issues with either confusion, as we mentioned, or memory issues, or affective symptoms. They may suffer from depression or things like that, which may be a delayed response to a head injury. And commonly in the past, we've referred to it with the global term of concussion, and we still use that from a diagnosis standpoint, and think of it, but the concussion in the past was largely thought of as patients that lost consciousness, and that was the criteria for a concussion. And what we're realizing is that concussions can take many forms, and mild traumatic brain injury can occur even though you don't have loss of consciousness. And we'll talk more about that as we look at the head rules and determine what are the rules that we can apply in this patient to decide if they need a CAT scan. One of the things that we find in patients with a head injury is the concept where they will have an immediate loss of consciousness or altered mental status, and then they'll improve rapidly. And they may have some issues of confusion or that. And one of the questions you have to ask, what's happening in the brain when those types of things occur? And initially with a head injury, there's some microscopic neuronal shearing that leads to a hypermetabolic state. And so the feeling is that this increase in blood flow to the injured area, just like when you have a bruise, it swells, you have increased fluid in the area, that same process is occurring in the brain. And then with alterations of cerebral blood flow and autoregulation in the brain, which occurs naturally in response to that increased flow and shutting down different flows and decreasing different flows, you may have those symptoms of confusion, or you may have initial issues in terms of motor response or balance and other issues. And so the important thing to think about in that is that it's a metabolic state. It's a state created by increased blood flow, and as that blood flow improves and as the autoregulation takes over in the brain, those symptoms should subside, or those symptoms will subside. And so it's something that as we're assessing the patient, we understand that the patient may have a temporary alteration of their mental status and their neurologic status, but then will improve as the brain goes through its normal adjustment process. In terms of assessing patients who have undergone or had a head injury, the history of what happened is going to be incredibly important to the patient's management and very important to the telehealth or the emergency telehealth provider who's going to be assessing the patient. And what we're trying to do in that setting is really recreate the event. What happened, and through that be able to make some estimation of the forces that were applied to the patient's head. What were the surfaces that the patient's head came in contact? Was it a wall? Was it a floor? Was it a concrete floor? Was it a wooden floor? Was it a rug? What types of things may you find in that in terms of getting some idea of the surface that the patient hit? Was there loss of consciousness or syncope before the injury? And this is particularly important in our older patients where they may have an event, either a cardiac event, an arrhythmia, or a seizure, some episode causing loss of consciousness before they had the event. Patients may have an intracranial hemorrhage or a subarachnoid hemorrhage and then fall and have or come in with a head injury when there was actually a pre-inciting event that may have occurred in that. Was there any seizure activity? Did anybody witness the shaking episode or things like that might be seen with seizure activity? And in this patient, is there any previous history of head injury, head trauma, or brain injury? Is there any previous history of CNS surgery? Have they had an operation in the past for a brain injury or for some brain lesion? So this history helps us evaluate and decide and put the patient's head injury into context with how they look on the exam. So any information from witnesses, from correctional officers, from other caretakers, from people that work with the patients will be extremely important in terms of deciding the context in which to place this patient's head injury. The next step is a physical examination of the head injured patient. And in many cases, this exam will be facilitated by the telepresenter in the telehealth setting, in the emergency telehealth setting. And so what are we looking for in that setting and that sign? The first thing we talked about was that rapid neurologic exam, doing a GCS evaluation and doing a GCS score. So some of the simplest points may be providing a stimulus for the patient, either talking to the patient or making sure that the patient has a stimulus to which they can respond. Checking the patient's pupils. Are they reactive? Are they equal? Do they respond to a light examination? And what are they pinpoint? Is again looking for that patient with altered mental status as a result of opioid use. Is this a patient that may benefit from Narcan because they have pinpoint pupils? The other thing that can happen with pinpoint pupils is a pontine bleed, and so there's other more serious problems that may occur if the patient doesn't respond as anticipated to the response to Narcan. The other thing you want to look at too is the overall motor function in this. And in the NIH stroke score, what we do is we have the patient hold both hands up or hold their feet up, and that gives you a real quick evaluation of the patient's ability and the motor function. And the other important part of the assessment of the patient is the assessment of their memory. Do they know where they're at? Do they know what happened? Do they know the events that happened? Oftentimes I find myself in the emergency department really getting into very fine detail with the patient to see if they remember the events. Do they remember, and can their memory be kind of jogged or improved so that they can remember the events and give you a better idea that they don't have any deficit of memory, or they do have significant deficits that need to be evaluated further. The other important piece is to rule out a basilar skull fracture or any kind of severe obvious head trauma. If there's a severe laceration and open skull, that's going to be very obvious. But the basilar skull fracture is something that's less obvious and has to be looked for on a physical exam to ensure that you identify it. One will be the battle signs, the ecchymoses located behind the patient's ears, dark areas. Hemotympanum, seeing blood behind the tympanic membrane, which can appear as a kind of a dark purple behind what is normally a clear tympanic membrane. And the best part I like about telepresenters and managing patients and nurses with examinations over in a telemedicine system is that we have symmetry. We can look at the other side and see are they the same or are they different. Looking for periorbital ecchymoses, those dark circles around the eyes. And finally, any CSF, rhinorrhea, or otorrhea. Clear fluid coming out of the nose or coming out of the ears may be a sign of a more serious head injury. The other important thing to assess for, as I mentioned before, it's airway with C-spine control. And as we go through the management of the patient, an assessment for a cervical spine injury will be an important part of this process. Palpating the neck to check for bony tenderness. Checking for the patients if they have any evidence of paresthesias or numbness, tingling of their extremities. Any evidence of incontinence or loss of bowel or urine in this process. The other thing, if there's no bony tenderness, is a range of motion. Can you take the patient, turn their head to the left, turn their head to the right, lift their head up and touch their chin to their chest? Do they have a complete range of motion in that process? And again, it's in a patient who's alert and not under the influence of any drugs or alcohol, and you can get a clear exam. Checking for extremity weakness, making sure that the strength is equal on bilateral. And in a more severe head injury, priapism may occur with a neck injury.
Yeah.
No, you're
Just
good.
let it run. Yeah, I'm forgetting I can edit. I'll find all sorts of nice pictures and of
No, that's what.
tympanic membrane. They'll
that's
put
what I was
normal on
thinking
it.
too.
Yeah, I got it all.
The other thing you can do is slip a video in
Mhm.
of, like with the mannequin, do
Yeah.
a jaw
Mhm.
thrust remover and
Or,
things
that's
like
the first
that.
thing. I may do that myself.
Yeah.
Hopefully we have a mannequin that has a jaw.
The next question that you'll need to ask in looking at, try that again. The next question that you'll need to ask in terms of managing a patient with a head injury is there a need for additional diagnostic imaging? Do I have to do a CT on this patient? When I'm doing a CT, I'm looking for more serious intracranial injuries. I'm looking for subdural hematoma. I'm looking for subarachnoid hemorrhage. I'm looking for cerebral contusions or injury to the brain with bleeding. I'm looking for an epidural hematoma. These are the types of serious problems that we're looking at, which will result in the patient requiring a neurosurgical evaluation or further evaluation. And when we talk about managing and whether we're going to have to do a CT or not, it's in the context of a patient who's had a brain injury, has symptoms that suggest that they might have a concussion or a mild traumatic brain injury, but now their neurologic exam is normal. And so the question I have to ask is, do I need to do a CT on this patient? And what are the things that can help me decide whether I'm going to do a CT scan of the patient. If you look at the application of rules in the emergency department, many times we don't use them very religiously to decide which patients get a CT scan, because the CT scan is very available in that setting. But there are disadvantages to the CT scan, whether it be cost in the facility setting, where you have to now move the patient to the hospital or move to an emergency department. There's the cost of travel and security. And then finally, there's the time and the ED throughput time that it takes to get the patient through the process and get them evaluated and possibly get a head CT in that setting. So you want to ask yourself, does this patient really need a CT? Or is this something that I can manage without a CT scan? And then the first thing you'll ask is which patients will benefit from a head CT. We've talked about some of the problems. If there's clear evidence of a basilar depressed or open skull fracture, that's a patient that will benefit from an immediate CT. If there's penetrating injuries, and in my experience over the years, getting an ice pick to the side of the head or a very sharp object could result in a penetrating injury, or a knife to the side of the head. If the GCS is less than 13, then it's clear from the literature that the patient will benefit from a CT scan. And if you have any focal neurologic deficits, meaning the patient has weakness in one arm or one leg, or has focal findings or facial droop, or anything that identifies that there's something specifically affecting a certain part of the brain. And in those patients, 6 to 8% of mild traumatic brain injuries patients will have intracranial injuries identified on CT, and less than 1% will ultimately require neurosurgical intervention. But again, those are the types of problems that we want to identify in this process. So what can we do? And over the years, the use of clinical criteria to guide the use of CT in mild traumatic brain injury has been a holy grail that researchers in emergency medicine have really tried to pursue. So there's been 20 years of studies that have come out trying to identify which factors will predict a patient who will have an abnormality on CT scanning and ultimately potentially require neurosurgical intervention. What they found over the years is that the best rules, meaning ones that have a high sensitivity, meaning if there's a problem there, you'll find it. And also that these tests, you want to look for tests that hold up under large studies or large applications of the rule, and lots of follow-up data managing those patients. And the two criteria that have come up the most and have the most support in the literature are what are called the New Orleans criteria and the Canadian CT head rule. And as you look at those criteria, they have different factors that they use in that, including the presence of age, factors of nausea and vomiting, what was the mechanism of injury, whether they have any significant pain, different factors that can be used to determine that this patient is at greater risk. Well, let's look at them a little closer, because we want to apply them in our setting remote from the emergency department, and again decide which patients may have a higher incidence of something that we have to find. The first mention that it is always that the application of the rule starts with a rock-solid normal neurologic exam, meaning that the patient, as you evaluate them, has returned to normal. And one of the key pieces of successfully managing patients in this setting is looking for those patients with rapid improvement, where they may go from a period of unresponsiveness to being much improved. And studies show that patients who normalize within 2 hours are very unlikely to have poor outcome. And that's probably a little long from the standpoint of the time frame that we usually go through with an evaluation, but it may be close to a half hour to an hour when we're seeing the patients, so we have a good opportunity during that time to see if the patient's improved. And many times we can watch them for a while to see if they're continuing to improve, if all of the trend in their management and in their physical signs and symptoms is improving toward the positive. And based on the best evidence that we have today, we can expect that an otherwise asymptomatic patient whose GCS score rapidly normalizes will not have a clinically important lesion on CT. So it's going to be important to see, does the patient improve quickly during this process. So making sure that they have a normal neurologic exam, that they're oriented to where they're at, time, place, person, and who they are and what they were doing. Making sure that their motor strength, checking that they can hold their arms up, hold their legs up. Watching somebody walk is an incredibly important piece where information can be gained in terms of how that patient is functioning. Because you're testing both their motor function at that time and you're checking their cerebellar function. Gait can be incredibly valuable in assessing that patient. And the other item along with gait is balance. Are they able to, the Romberg, holding their hands up with their eyes closed with somebody hands on either side to make sure that they don't fall. But checking gait and balance can be extremely important. And once you have a patient, now we can talk. Once you have a patient that's improved and recovered, or never really has had any significant loss of consciousness, now we can start talking about the application of the head injury rules. And there's a few factors that are seen in both of the rules that we have available. And it's interesting too, when we're trying to manage a patient, sometimes we'll use one set of rules if they have certain symptoms, and another if they have another, because there's a little bit of differences in them. But both of those sets of rules have been validated and are legitimate here. But what are the things that both of them have in common? One is age, and the patient with greater age is a concern in the setting of a patient with a head injury. And one of the factors that both head injury rules have in common is the factor of age. And both of them identify, one at age 60, another at age 65, that we have to consider age as a concern. And what we find is that when we look at the patients with older age and trauma, is that the risk of intracranial injury increases directly with advancing age. And once you get age greater than 75, these patients have the highest rates of traumatic brain injury related hospitalizations and death. And the other thing that we find in elderly patients is that they may not show clinical cues, including loss of consciousness. They may not show that as well as younger patients. So the important thing to remember is to maintain a low threshold for getting a CT in patients with greater age. The other factor that I've seen over my years of emergency medicine is a patient with nausea and vomiting, and oftentimes that can be of great concern when you have a patient who you're seeing and they just get more nauseated and they're vomiting. That's a patient that's worrisome in terms of them having an intracranial injury that's going to require intervention. That's the patient who I see in the trauma room with nausea vomiting that I try to get immediately over to the CT scanner. And so it's something to look for in the patients that we're seeing. The other thing to look for that both of the rules have is visible trauma of one above the clavicles. And what we're looking for those is severe lacerations, evidence of a basilar skull fracture. It's the fact of whether a patient may have a hematoma or abrasion. It may go just with the fact that they bumped their head. So the question will be, what other signs and symptoms may you have with a patient who has a bruise on their head? That means that they hit their head hard enough to cause a bruise, but did they hit it hard enough to have an intracranial injury? So looking at it, we want to look for evidence of very visible trauma that could be of concern and that would be monitored. If a patient has a hematoma but has no other signs and symptoms, is that a patient that we can manage? Very possibly. If a patient has a hematoma on the side of their head and you're concerned about the possibility of a parietal skull fracture, then that may be a patient that the location of that hematoma may be of greater concern. Other things that we look for when applying the New Orleans and Canadian head rules, CT rules, is the concept of headache and severe headache. And one of the rules has them in it, the other doesn't. And so it means that it's something that you have to take into consideration as you're looking at the patient. And again, understanding that it's a very subjective finding, but oftentimes you can get that impression on evaluating a patient that they have severe pain and that it's something that is requires evaluation in that. The other item that they mention in that is a dangerous mechanism of injury. And many of the ones we're not going to encounter in evaluating patients in residential facilities or correctional facilities, such as ejection from a vehicle or other things, but looking at it from a standpoint of a fall from a height greater than 3 feet, so the patient was standing on something and fell from that height, or they fell down 5 steps, would be something that would be concerning, would be a more dangerous mechanism of injury. Being struck with a projectile, a small area, the ball peen hammer is the best example, but it's a very high velocity of force applied to a small area, is a dangerous mechanism that would be of concern as we're evaluating the patients. And finally, the third area to consider is the issue of seizures during an event or during a head trauma, or a patient that you're evaluating for head trauma. And in evaluating patients with seizures, the most important thing is, do they have a history of seizures? Are they on antileptic medication? Do we have an ability to estimate what their levels have been? If they've been off their medications for several weeks, then the likelihood that they have an adequate level is very low. So can you, in that, identify a patient who has a seizure history? The key with managing seizures is that the patient ultimately returns to their normal baseline. And so making sure that even though there may be a postictal period after a seizure, the patient returns to a Glasgow of 15, or I say a Glasgow of 14 and 9900ths, to make sure that they're at that level. I also tell the residents what's a Glasgow of 16, and it's if the patient can make me laugh, that indicates a higher level of functioning. But I really want to see in a patient with a seizure that patient has returned to a normal exam and a normal mini-mental status following a usual postictal period. But in terms of managing patients with a seizure, one of the other problems is we don't have a good idea of what happened. How far did they fall? How did they fall? So looking at that patient a little closer with seizures to try to get some idea of any evidence of physical trauma above the clavicles following a seizure? Is there any evidence that with the seizure the patient had a fall? Were there any witnesses around during the seizure that said that the patient, they were able to catch the patient, or they were able to make sure that they didn't fall with that? So again, considering the seizure as a concern. If the patient seizes following the head injury, that's concerning also, meaning that the patient had a more severe loss of consciousness following that, and particularly if the history tells you that it was a more severe injury or a more severe event. So if I'm assessing a patient in a facility, what are the things that can get me into the 12 to 13 range, which is that point of deciding that I'm going to have to go ahead and get a CT of the patient. And again, it's that the symptoms have now been persistent despite watching the patient or observing the patient for a short period of time. And one of them will be if the eyes are persistently closed, that the patient is not opening their eyes and looking about. If their verbal response is confusion or inappropriate words, and one of the things that you'll find in patients like this is perseveration, where they keep saying the same thing over and over again. And that's an indication of inappropriate words or confusion, and has to be accounted for in deciding whether this patient needs a CT or not. And then finally, from the best motor response, the one that gets you a point off may be that they don't obey commands. And this is going to be sometimes subjective in terms of assessing a patient on how purposeful they are in their kind of response to the stimuli. And if their response is very purposeful and very, then you want to watch closer or continue to evaluate that patient to see if there's additional evidence that tells you that that patient is more responsive and is able to respond to you. So again, and what are some of the confounders when you look at eye opening? Is the patient who's closing their eyes and doesn't want to open them. In a vest verbal response, sometimes the concern is there intoxication, and is there some evidence, is there something on board? Most of the inhalants may take less time to wear off, so you can continue to see. But the key for looking at a patient where there's a suspected intoxication and the possibility of a head injury is watching them over time and making sure that you continue to see a steady and rapid improvement in the patient's level of consciousness while you continue to watch them. And again, getting back to that idea that, people ask, well, what's unresponsive? And the, whether you decide if it's unresponsive is really based on that you've provided a stimulus and what is the response. In keeping with the patient, it's very reasonable to keep asking them, making sure that you continue to get a good response and you continue to see the level or the progress of, is this a continually increasing level of consciousness, or is there some change and alteration, or they're not getting better. One of the things to consider in assessing the patient with the altered level of consciousness is what we call in ER the rally pack. And that's check a glucose, check a D-stick and finger stick. And then the other is use of Narcan. And oftentimes that may be one of the first things that you want to do is see if there's a response to Narcan when you have a less responsive patient, and as you're assessing for the possibility of a head injury. One of the questions that comes up is, do I always have to get a CT if there is loss of consciousness? And it's interesting as you look at the both the Canadian and the New Orleans head injury rules that loss of consciousness is not a factor in that. And part of the reason is that the first studies that were done only on patients that had lost consciousness, and then later studies that were done managed patients with both loss of consciousness and others that didn't have loss of consciousness. And what they found in there is that the presence or absence of loss of consciousness really didn't predict those patients who had a more severe intracranial injury or the need for neurosurgical evaluation. So the loss of consciousness, as we mentioned, may be caused by local factors, but the real key is how quickly did they respond, or how quickly did they improve in that? Because loss of consciousness in and of itself found that that really wasn't a major factor in determining whether a CT was indicated or not. And these rules can be applied in patients who have loss of consciousness and those who don't have loss of consciousness. So again, you can manage a patient without a CT if there's been loss of consciousness, but the requirement would be that they have a rapid level of improvement, they have a normal mini-mental status, and or a normal neurologic status exam, and they don't have any of the high-risk factors discussed elsewhere with the criteria. And finally, what about the patients who are on Coumadin, novel anticoagulants such as Pixaban or Dabigatran? What about those patients? How about patients that are on aspirin or Plavix? These are common agents that are oftentimes in our patients, and the factor that we'll find in looking at these patients is that there's strong evidence to support the use of immediate CT on all patients with mild traumatic brain injury taking anticoagulants. So the patients who have an alteration of mental status, who have evidence of a significant injury, who have an alteration in their Glasgow coma around 13 or 14 rather than 15, and they're on Coumadin or they're on anticoagulation, that's a patient who does require a CT scan. And one of the problems is, particularly in patients on Coumadin, we don't know the INR level at the time we're seeing them many times in the residential facility, so we really can't determine whether there's an increase of bleeding or an increase of bleeding down the road. So the goal in terms of managing patients on anticoagulants is oftentimes, if you have evidence that the patient had a significant head injury or a mild traumatic brain injury, to have that patient transported to get a CT scan. So finally, in summary, what we've talked about are the initial response to a patient with a head injury, remembering your ABCs and making sure that you're practicing airway with C-spine control and the jaw thrust maneuver, making sure that we evaluate patients from a neurologic standpoint, that we do a good history, or we try to get as much information as we possibly can about the events surrounding the head injury, so that we can get a better idea of the forces that were applied to that patient, making sure that we can do a neurologic exam. And I've always said one of the neuro exam is one of the easiest things to do over a telemedicine system, because I can pretty much do on the telemedicine what I can do when I see the patient in the ER. I can assess their motor strength, I can assess their gait, I can assess their balance, I can do finger to camera and have them be able to do things that assess all parts of the brain, including the cerebellum. So making sure that we do a good neurologic exam. And if we have a patient that has evidence of a mild traumatic brain injury, utilizing evidence-based criteria, the head injury rules in this setting to decide which patients are going to need a CT scan and are going to need further evaluation to rule out intracranial injury. So I hope you found this helpful in terms of assessing patients with head injuries and mild traumatic brain injuries, and moving forward more effectively using our emergency telehealth systems to manage patients effectively where they're at.